Welcome to the JEMS Report, brought to you by Clarion Events, Fire and Rescue Group, and the Journal of Emergency Medical Services. My name is Ted Lee, and I'm the Editor-in-Chief of JEMS. Along with Jeff Frankel, our Managing Editor, we are bringing you guests with subject matter experts and industry leaders on all topics touching pre-hospital medicine and EMS in general. And today we've got two very special guests. Of course, this is Heart Month, so we're going to be talking about cardiac arrest and programs. Dr. Kate Tataris, EMS Director for Chicago EMS System, Associate Professor in Emergency Medicine at the University of Chicago, and Chris Powers, Paramedic-in-Charge, Instructor, and coming from Chicago Fire Department. Thank you guys for joining me. Okay. I really appreciate the time taken out of your day. And Dr. Tataris, why don't we give our audience a little bit more about your background and what you're bringing to EMS.
Thank you for the introduction, and thank you, Chris, for joining us. My name is Katie Tataris. I'm the EMS Medical Director for Chicago EMS. Also, as you mentioned, I work at University of Chicago. I'm an Associate Professor of Emergency Medicine there. And part of my role as the EMS Medical Director is to provide pre-hospital care and oversight for the City of Chicago with three other medical directors as part of a consortium model. So really happy to be part of that group. I also work with Illinois Heart Rescue. It's a statewide group to improve cardiac arrest survival in the state of Illinois. And I've been in my role for 10 years here.
Great. And Chris?
Hello. I'm Chris Powers. I'm a paramedic-in-charge with Chicago Fire Department. I work underneath the Medical Administration and Regulatory Compliance Division for our fire department. For all intents and purposes, essentially what I do now is I'm basically like a quality manager for cardiac arrest care. I review all the cardiac arrest and traumatic arrest cases that we respond on. I've been with the fire department since April of 2004. I've been working in this capacity in the review process and teaching cardiac arrest management for about 2.5 years now.
So we had a guest from the Illinois Heart Rescue a few months ago and had a little bit of a back and forth with information about that program. And it seems pretty unique. So how does that program interact with you guys in Chicago?
So Illinois Heart Rescue is a statewide group. And again, the goal is to improve cardiac arrest care throughout the state of Illinois. One of our biggest focuses is the city of Chicago with 3 million people. It is a very large geographic and population-based source of our patients and our cardiac arrest in the state of Illinois. And so we have spent a lot of our time focusing on, how to improve cardiac arrest care, both with an AED program, working on bystander CPR rates, and getting EMS reports into CARES, and then trying to engage our whole state and working at our numbers and just trying to get better.
So you mentioned CARES. Could you give me a brief overview of what the CARES program is?
Yeah, CARES is the Cardiac Arrest Registry to Enhance Survival. And we've been submitting our EMS and hospital data to CARES for over 10 years now. And it helps us measure and improve on how we're doing with our cardiac arrest bystander CPR rates, our shockable rhythms, and our survival outcomes from the hospital. So it's a really good way to measure and look at your data across the system and see how you're doing and improve on the parts that you need to improve on.
So could you give a little bit more information? I mean, you mentioned Chicago and the demographic and the population being quite large. I would imagine that you guys are drawing quite a bit of information and have a lot of moving parts in your program. Could you give us a little bit of the history of coming up into this year about cardiac arrest survivals, and what you're trying to do out there?
So every year we look at our CARES data, which is basically our annual report of how we're doing. And then we focus our education, our training, and our quality improvement on those gaps. We've been, again, submitting to CARES for over 10 years and focusing our care on, the out-of-hospital cardiac arrest care. Chris Powers is instrumental in this and kind of working with our EMS clinicians and getting them engaged in cardiac arrest care, and then working on our, good patient care when you reach the patient, and then all the way to the hospital to have good outcomes.
So, Chris, could you tell us a little bit about the QA, QI program and what you have set up and kind of how you are interacting with, Illinois Heart Rescue and the CARES program data?
Sure. Yeah, so basically, like I said earlier, what I do is I review all the cardiac arrest cases and traumatic arrest cases that we respond on. These are also reviewed by Region 11. That is who we answer to. Those are our resource hospitals. We have two paramedics that do it. It's myself and Master Zalka does it as well from the region. And so essentially the process is, for me, is basically I would look at, the patient care reports initially, and then I also look at, the data inside the platform that we use for our monitor, which is the Zoll monitor. I look at RescueNet. And by looking at the patient care reports and then looking at the corresponding RescueNet data, I could kind of get an idea of how the arrest went, right? And at that point, most of our arrests are generally run really well. Sometimes maybe they're not run well. And if that's the case, usually it's a process of maybe bringing this crew in and just going over like our cardiac arrest management protocols with them in a class that we teach. The class is called Cardiac Arrest Management. It used to also be called Incident Command for Cardiac Arrest. That's usually about a 2 to 3 hour class that I teach. It involves hands-on simulation, and it also involves a didactic portion where we review, the Region 11 protocol, local protocols, and just kind of refresh our members as far as like what they should be doing on these cardiac arrests. So generally, that's what drives our education, right? It's just me seeing it, right? Identifying it, and then bringing the crews in for a review process. And the review process is never like punitive or anything like that. It's simply a matter of like a review of a play. That's how I like to call it to people. I say it's like, when you watch these sports teams play, it turns into like, a play goes good or a play goes bad. And oftentimes you'll see them review the play immediately. With the technology that they have now, you can do it like right on an iPad. So I like it the same way with us. I can say, look, this is what I saw. I'm just a coach on the sideline reviewing the play with you. And here's what I think maybe we can do better next time, or here's what we did great, right? And so that's basically how I approach my work.
Yeah, and today with all the technology that we have and the ability to collect this data, how different is it from 5 years ago, 10 years ago, when it's just straight chart review and maybe somebody was on scene that was able to kind of view how a call was run and maybe be able to intervene?
Well, it's much different in the sense that, just how the monitor technology changed, how the data has changed. I would imagine it's different. Again, I've only been doing this for 2.5 years. However, prior to my tenure of doing this for the last 2.5 years, I did have some predecessors before me, that also did a similar process with a different monitor. But the process was essentially kind of the same. And it was, through the work of Dr. Weber, through Stroger Hospital of Cook County, and Pete Lazzara, they kind of championed this whole program we have here of ICCA, or Cardiac Arrest Management. And they had a process down that is very similar to what I'm doing. So basically, I'm just using a lot of what they did and kind of just, continuing it, if you will, right? Which is looking at, the review process, patient care reports, which is what they did as well, and looking at the data on the monitor uploads, and then reviewing it and seeing, hey, what do we have to do? So they basically did the same thing. I'm just, carrying that torch forward right now. As far as the technology goes back then, like I said, it was a little bit different. Again, we'd use a different monitor, but the process was basically the same.
So, Dr. Tataris, from a physician standpoint, looking across what the crews are doing, I would imagine that you're seeing that the technology really advance and kind of make the job a little bit easier and kind of keeping up with the crews and kind of what's going on.
Yes, we've been through some different technology updates. We really think the metronome is a very, a great tool because it allows our compression ratio and our rate to stay the same. And then now we have these kind of auto downloads with the data in terms of every cardiac arrest. You hit a button and you can see a summary report. We used to have to annotate and it would take some time, but now it's a fairly quick process. So I think the metronome is great. We now have a puck accelerometer that helps us know how deep we're compressing or compression depth. So there's a bit of technology just with the monitor change that we've had with Zoll. And then I think the future is ventilations. That's something we don't quite focus on as much as we probably should. And I think the data is also showing that this is important for survival, and ventilation is important. So I think that's probably the next frontier of what we need to measure and get better on.
So with all the focus on cardiac arrest and cardiac care, and of course with it being Heart Month, the internal service things, we see that EMS providers, physicians are doing a lot to make an impact, but that impact is just one link in the chain that we've been familiar with on the chain of survival. So what are you guys doing with the other bits of the chain, and specifically the community aspect of it?
Yeah, so I'll start at the beginning of the chain. We actually have focused a QA process on our dispatch center, and focusing on having the dispatchers recognize out of hospital cardiac arrest, and then having them start compressions on, unconscious, not breathing. So that's been a big focus in our QA process. Illinois Heart Rescue has been great with targeting neighborhoods that are lower bystander CPR rates and focusing on, those groups. And we've actually significantly improved our bystander CPR rates across the city of Chicago with that intervention. And then past the EMS stage of responding in patient care, it's then the hospital system, and kind of that's the last chain in our system of care. So having designated STEMI centers, providing good post-resuscitation care, and then getting those patients to walk out of the hospital with good CPC scores.
So back to the community aspect, if you're identifying hot pockets or pockets that need a little bit more resources, how are you guys dealing with that, and what kind of programs are you putting in place to try to address those needs?
That is through Illinois Heart Rescue, and we actually have information about where our bystander CPR rates are and need to be worked on. And we actually have groups that go out and target those communities and those populations, culturally appropriate educations, trainings, different types of mannequins with different skin tones and, genders. And so it's really great to have that focus on the community aspect of things, so we can kind of focus on the other links in the chain of survival from the EMS system and the fire department side of things.
So kind of since this collection of data and the identification of communities in need, what has that done to the rates? How have you watched the data change, over the years of these programs?
I mean, in general, our cardiac arrest survival rates, so our withstand bystander rates, are almost 5 times what they were when we first started, which is a huge, huge success accomplishment. And that's, thanks to the entire system of working together to get to where we are now over the last 3 decades. The bystander CPR rate also have significantly increased, or almost at 50% now of patients that have bystander CPR. And again, that's kind of focusing on those communities that were low and trying to get those numbers up.
Are you seeing an increase now that you have a data set and you're seeing positive trends? Are communities responding with that as well? More interest in participating? Are there certain aspects of the community that are more willing to do these type of programs or assist with these programs?
I think it takes time. I think it takes trust. I think it takes showing results from the community side in particular. And then, Chris will tell you with the fire department, when we started this program, 15 years ago or so, how kind of just getting EMTs and paramedics on board and like seeing patients get ROSC in the field, and how big of a change that was for people to see, hey, this actually works. So Chris has that kind of firsthand experience, and then just seeing our numbers go up every year, it's like, this actually does work, and here's our data to prove it.
Yeah. Well, I mean, that's one of the things that we've always noticed is, anecdotally we thought or believed, well, we are making a difference, but then everybody asks, well, what are your numbers? And you're like, oh, well, we'll have to cycle through stacks and reams of paperwork just to try to pull up those numbers, and it's so difficult to do that. Nowadays, it's a little bit easier. Chris, how are the crews responding to the education aspect of it and the community relations aspect of it?
As far as our crews, I think the response is really well. I always have for the most part, very positive reviews when we do the training, incident command for cardiac arrest or cardiac arrest management training. And, we've seen, like, Dr. Tataris mentioned, just this gradual, for the most part, an increase over year of, survivability, right? Or survivability rates. A lot of it is attributed to simply, I think, like she mentioned, which is bystander CPR, right, which is big. That also involves a lot of what we call the alarm office, where our 911 call takers will help with that. But also, it does involve, I think, a lot of our training that we have, right? And so, the reason why we are at where we are today with the crews doing the good job that they're doing is, again, getting back to, if you go back to 2012 or so, when we first started really doing this type of a program, which is like, a team-based approach where we, have all of our responders are essentially, very involved in a specific role. The whole introduction of the whole, pit crew type CPR, that's what it's called in a lot of places across the country. Our term initially, like I said, was called incident command for cardiac arrest, but it basically is that same concept, right? And all of our crews just kind of know that's what they need to do, right? So when they respond to the scene, they know, like, hey, this is my role. This is what I'm going to do. I'm going to be the compressor. I'm going to do ventilations and so forth. And they all kind of go right to task. I think Dr. Tars might be able to speak a little bit better about how the community involvement end is. I will say in the review process, when I look through patient care reports, just anecdotally, I can see that, there seems to be a higher amount of cases where our paramedics will put in their narrative, CPR is being done by family or something like that, right? So I do see a pretty high frequency of that occurring.
Well, with and you mentioned, the team dynamics and the telecommunicators being part of this, bringing them on board and making them comfortable with the process of trying to talk somebody through how to do CPR and how to do it correctly. I'm sure it took a while as well for the comfort level of them.
Yes, and the dispatchers, that did take some time. And again, we do have some patients that have abnormal activity, like convulsive type activity that, initially the caller thinks it might be a seizure and it turns out to be ventricular fibrillation. But we don't know that till we get there. So again, if they're, not breathing normally, no response, unconscious, then we start doing compressions and then, get a trained personnel on scene as soon as possible to further assess and hopefully shock a shockable rhythm.
So Dr. Charles, you mentioned the hospital aspect of it. So, once all the field aspect and the culture's kind of changed in the field, how is the hospitals, the area hospitals responding to this? And are they doing outreach into the public as well?
Designated STEMI centers, which again provide 24/7 cardiac care, cardiac catheterization, and then targeted temperature management. Again, with the goal of getting these patients the best chance of survival when they walk out of the hospital. We have worked with our hospitals every year as part of the CARES data. We look at the hospital scorecard and how they're doing, how many patients are, having a TTM intervention, and then how are the numbers. So I think hospitals are looking at this and just kind of letting people know you're looking at it as step one, and then trying to get a team to focus on how well you're doing and then to improve is the next step. So I think that's it's a work in process. We have a very big city, and some hospitals get more patients than other hospitals, and some hospitals have more active programs. But again, we want to give patients the best chance they have for survival and integrating all these steps in our system of care.
How often do all the key players get together to discuss what's going on?
But through the American Heart Association, we actually have monthly STEMI data meetings. So all the STEMI centers that are submitting data to our database, again, looking at outcomes, we get those numbers too. In terms of the CARES database, that's just once a year to look at your report card. But again, part of the STEMI system of care, which kind of interfaces with the cardiac arrest system, we do those meetings every month.
So with that, what does the future hold? I mean, what do you guys see the next step of this process? I mean, you've been doing it for a while. You've got incremental gains, and are really starting to make a difference as the culture shifts. What's next?
Great question there. What's next? I mean, I can give you some of my ideas. I'm sure Dr. Tataris can share some of hers. I mean, we are doing a really good job with, like I said, compared to what this department was, 20 years ago when I came on, right? 20 years ago when I came on the fire department, there was no cardiac arrest management. It was, you got a person in the house and you maybe put an airway in them and you did some, CPR, if you will, on the way out to the ambulance and you drove to the hospital. Now with the whole advent of, working patients where they're found, there was a big culture change, 10, 12 years ago. But now, like I said, it's just muscle memory. We just do it every time. As far as the future goes, I mean, I think I could see it evolving at some point, maybe where, we don't transport as many cardiac arrest patients, maybe, right? Like, we have maybe more advanced care happening. But, I'm fine with where we're at now. I think we're doing a great job. I mean, there are some cases where we can do better, but, I think the goal for me would be, I mean, just again, speaking for me, not for Dr. Tataris or anybody else, would be to just work our patients on the scene. I would love to be able to see, the ability to have like some sort of like live feed, if you will, with the hospital to say, look, maybe we can't do any more for this patient, right? Because we know when we start packaging a patient or preparing a patient to transport, we're going to stop doing CPR, and then we're on the way to the hospital. CPR is ineffective, right? So again, just get back to like where we've taken us to this point, which is working patients at the scene as much as possible. I think we could see that maybe in the future being the just the be all end all right there, right? So Dr. Tataris can explain. We do work patients, and we do have termination criteria. It's quite specific, but we do that. We do practice that here in this system, though, too.
And I was going to say, I will add that we have expanded our cardiac arrest management approach to pediatrics. When traditionally we grabbed a kid and ran, because that's what you do when you're, nervous with a pediatric cardiac arrest. We've really tried to push hey, any cardiac arrest, doesn't matter how old they are, start your resuscitation where you find them. Let's get a rhythm. Let's open the airway. Let's shock a rhythm. Let's get an IO. Let's do some epi. So we're trying to do, again, care at the patient side, and again, trying to focus that to the all ages pediatric patient, because again, the best chance we have for survival is starting that care right away. So for me, that's number one. And the second one is the EMS witnessed arrest. We have a large percent of patients that are kind of peri-arrest, very sick, and then just lose their pulse in the process of getting to the ambulance or in the house. And the question is, can we do anything to address that process, reverse that process, stabilize them, and prevent the arrest that we're kind of seeing on the rhythm strips. So I think that that's something we've, Chris put a great education together on that. And I think that, again, looking at our data, that's something that we can focus on. Like, can we make an outcome change here? So to me, that's the next intervention phase.
Great. Well, we're wrapping up on time, and I want to thank you both for taking time out of your busy days to talk about this with us. Any closing messages that you'd like to get out to those listening to us?
It takes hard work. It takes a team. It takes dedication. And if you have an off year like we did during COVID, keep at it and the numbers will come back up. So it's a team approach. And again, that's all the way through the whole system of care, from dispatchers, bystander CPR, EMS, the hospitals, and then hopefully getting as many patients as we can out of the hospital alive. So for us, a 1% increase in survival is 30 more patients. So it's a big number when you look at like how many patients will be alive after this intervention. So it's on a personal level very important for our community.
Yeah, for me, it's just, a matter of just, finding somebody that, really makes a difference, almost like a behind the scenes person, a champion or whatever. Like I mentioned earlier, for me, it was, Pete Lazara taught this class when I was in the field that I teach now. He's since retired, but that person there was really a person that really made things happen and really drove some change. So you need to find that and make sure it's a collaborative effort between that person and your hospital base, like whether it's like your resource hospitals or a person like Dr. Tataris is on board. That'll make a big difference for sure.
Well, great message. And of course, Heart Month is only 1 month out of the year, but it's an everyday type of thing. We can't just bottle it up and go, oh, we're only going to pay attention to it in February. So once again, thank you for spending time with me today. I really appreciate it. And we're going to look forward to hearing great things out of Chicago and what you guys are working at. And you're always welcome to come back and give us updates.
Thank you. Thank you for having us.